Hi, my name is Pamela Coons, Associate Professor of Medicine in the Division of Oncology at Yale School of Medicine and Yale Cancer Center. I'm excited to announce ASCO's new open access journal, JCO Oncology Advances. As the inaugural editor-in-chief, I hope to support JCO Oncology Advances to become the premier platform to bridge the gap between accessible scientific research and clinical care. Stay tuned for more information, including new article types, at ascopubs.org/JCO Oncology Advances. We look forward to seeing your submissions in spring of 2024.
This JCO podcast provides observations and commentary on the JCO article, Long-Term Results of RTOG 9111, a comparison of 3 non-surgical treatment strategies to preserve the larynx in patients with locally advanced larynx cancer by Arlene Forestier et al. My name is Paul Harari, and I am the Jack Fowler Professor and Chairman of the Department of Human Oncology at the University of Wisconsin in Madison, Wisconsin, USA. My oncologic specialty is radiation oncology. Each year, over 520,000 patients worldwide are diagnosed with head and neck cancer, and approximately 1/4 of these, 130,000 patients, close paren, have larynx cancer. In light of the critical function of the larynx for speech and communication, there is a high quality of life association with preservation of a functional larynx. In 1991, the landmark VA Larynx Cancer Study Group trial was published, identifying that many patients with advanced larynx cancer could be treated successfully without total laryngectomy using non-surgical approaches with radiation and chemotherapy. Following this theme, RTOG 9111 was designed to test 3 non-surgical treatment approaches for resectable stage 3 and 4 larynx cancer. 547 patients with stage 3 or 4 larynx cancer were randomized to treatment with induction chemotherapy using cisplatin 5-FU followed by radiation versus concurrent cisplatin radiation versus radiation alone. The primary study endpoint was laryngectomy-free survival. The first mature report of this important trial was published in the New England Journal of Medicine in 2003 with a median follow-up of 3.8 years. The current report extends the median follow-up to 10.8 years and provides strong confirmation of the original report findings, in addition to several new considerations. Let us review and discuss several of these key findings. The most compelling result from this large multicenter larynx trial is the finding of superiority for concurrent chemoradiation using single-agent cisplatin over induction chemotherapy or radiation alone to achieve larynx preservation and locoregional tumor control. This key finding has been well maintained with 10-year follow-up as described in the current report. Although this outcome may seem intuitive to trainees of the current era, this was certainly not readily apparent in the early 1990s that concurrent administration of chemotherapy with radiation in head and neck cancer would be a preferred strategy. In fact, there was considerable concern that significant toxicities might accompany such a concurrent approach, and therefore the dominant investigational strategy of the era involved hyperfractionated radiation alone or sequential chemoradiation using induction chemotherapy for 2 to 3 cycles prior to radiation. The outcome advantage with concurrent chemoradiation in RTOG 9111 amplified findings from a comprehensive meta-analysis in head and neck cancer reported in The Lancet in 2000 by Pignon and colleagues, where updated data from over 10,000 patients from randomized trials of chemotherapy impact identified the best tumor control and survival outcome for patients receiving concurrent chemoradiation. This meta-analysis was expanded to over 16,000 patients in 2009, confirming a clear advantage for the use of concurrent chemoradiation over induction or adjuvant chemotherapy strategies in head and neck cancer. Absolute survival differences in larynx cancer represent a challenging target to achieve in clinical trials. Larynx cancer patients enjoy higher survival rates than several of the other common head and neck cancer subsites, including oral cavity and hypopharynx, for example. This renders a greater challenge to establish absolute survival benefit with new treatments, and indeed all three arms of RTOG 9111 demonstrated similar survival rates with 10 years of median follow-up. For unknown reasons, there were an increased number of deaths in the concurrent chemoradiation arm that were neither attributable to cancer or to treatment toxicity. Although this finding did not detract from the clear superiority of concurrent chemoradiation for larynx preservation and locoregional tumor control, this may have blunted the potential to capture a long-term survival benefit for this cohort of patients. There's little doubt that concurrent chemoradiation patients enjoyed an improved outcome in the overall picture, since nearly twice as many patients treated with induction chemotherapy or radiation alone required treatment with subsequent laryngectomy. Concurrent chemoradiation strategies in head and neck cancer provide the highest rates of tumor control, but this approach is also accompanied by higher rates of toxicity, particularly acute mucosal toxicity as confirmed in this trial. Intensity-modulated radiation therapy techniques were not available during the conduct of this trial, whereas IMRT is now the dominant treatment approach for radiation delivery in head and neck cancer in 2012. This refined radiation delivery technique can not only reduce dose to skin, salivary glands, and mucosa distinct from the primary tumor, but also limit dose to late-reacting normal tissues including brainstem, spinal cord, mandible, swallow musculature, and carotid vessels that can impact adverse effects in patients who are long-term survivors. Efforts to reduce long-term normal tissue toxicities in head and neck cancer patients are very important, particularly in this era of concurrent chemoradiation, where patients experience substantial acute toxicities in an effort to maximize tumor control rates. RTOG 9111 represents a pivotal trial in head and neck cancer and a defining study in the evolution of larynx cancer treatment. This study confirmed the VA Larynx Cancer Study Group finding that over two-thirds of resectable larynx cancer patients, T1 and high-volume T4 primary tumors excluded, can safely preserve their larynx with non-operative treatment strategies. This trial further highlighted a distinct advantage for the use of concurrent chemoradiation, where over 80% of patients in this arm achieved larynx preservation. In concert with two major trial reports from ASCO in 2012, the Paradigm and Decide trials, where induction chemotherapy followed by concurrent chemoradiation showed no improvement in overall survival compared with concurrent chemoradiation alone for advanced head and neck cancer patients, the mature follow-up report of RTOG 9111 supports the use of a straightforward treatment regimen of radiation and concurrent cisplatin for many patients with intermediate to advanced stage larynx cancer. This approach affords a considerably less toxic, less time-intensive, and less costly approach than those that incorporate induction chemotherapy. Further refinement of conformal radiation techniques, rigorous clinical trial assessment of endoscopic larynx conservation surgery approaches, and the optimal incorporation of molecular targeted therapies remain active areas of investigation to further improve overall outcome in larynx cancer. RTOG 9111 is an important head and neck cancer study to maintain in your library file of milestone reports. The authors, the cooperative groups, and the many patients that have dedicated their efforts to improving outcome for larynx cancer patients are to be congratulated for these valuable efforts. Nevertheless, there is still more to accomplish to further enhance larynx cancer cure rates and overall quality of life for these patients in the years to come. This concludes this JCO podcast. Thank you for listening.
For more original research, editorials, and review articles, please visit us online at jco.org. This production is copyrighted to the American Society of Clinical Oncology. Thank you for listening.